this keynote is about health system transformation, right? So there's some driving context, the overriding context that is causing us to need to change and transform. So what are these, right? So I will paint out two big contexts. Right? First is actually the rising costs. So you can see the Singapore government healthcare expenditure year to year has been increasingly steadily, about 15% growth throughout the years, from 2.2 billion Singapore dollars to almost $19 billion in last year. And the increase has been relentless. So arising from this, right, the second context is the Ministry of Health in Singapore has actually um, requested for all the public sector, regional population health systems and hospital clusters to actually prepare for the future using these three key shifts. So the three key shifts, right? The first shift is actually to move beyond the hospital into the community where we begin to manage regional health. So that is the context where acute hospital and a community hospital coming together, right? And then we start moving into the community to actually engage people in wellness and prevention as well, right? Also partnering with GPs a lot more in our community to transform primary care, and then starting to work on aging care services in the community to prevent frailty from getting worse in the community. So this first trust, or the first beyond, right, beyond hospital to community. The second is that we want to be able to measure value to patients, measure value to the system, not just quality. So this involves not just appropriate care, but also appropriate care from medical perspective, but also valued care, appropriate care to patients and relatives of caregivers and family, right? What is considered appropriate to them, value to the patient and value to the family members. So it involves a lot of thinking through how to measure value instead of quality, and then making the right changes to produce it. One of the biggest cost drivers of cost is actually manpower cost. So we also have to make healthcare manpower a lot more efficient through innovation and job redesign. So that's the second trust, quality to value. And then the third is to really pursue not just disease care and care when people have fallen sick, but try to promote healthy aging, prevention, and then moving upstream. So this was one of those few things that we started to do since 2014 and beyond. And up till now, we are still trying to transform the whole system in order to deal with these two contexts. All right. So in response to this, right, this is the background for Yishun Health System transformation. So I'll introduce two strategies, two systemic frameworks to help us to think about this, and I'll give examples around this. The first systemic framework that guides us in systemic design is actually this framework from the World Economic Forum, where we talked about population segmentation, segment-specific intervention, and systematic measurement working in tandem in a continuous improvement loop, all right? So this is kind of like a systemic cycle, right? A leads to B, B leads to C, and then C leads back to A, right? So this is a value-driven strategy to help populations achieve population health outcomes. So right at the left side here, first it starts with population segmentation, and the key activity here is actually to understand we are integrating care for which population, and we need to have population segmentation models to help us understand the population segments, the people and the residents and patients that we care for, right? So that's about population segmentation. And once you have defined a population segment, then you can begin to define specific segment-specific interventions, right? Care services, healthcare services, disease care services, right? You can integrate them in a way that targets that segment, right? So this is where we find design most useful, and models and care services models that help us think about better services and better integrated care for those individual populations. And then once you have a model of care and you have a population segment, you can begin to measure the outcomes for each population segment as well as the care and services outputs and process indicators such as experience, right? And you can measure that, and then you see whether or not they are getting what they need to get better health and better healthcare outcomes. So that leads us to performance measurement models. So because this runs in a continuous improvement loops, you will understand that whatever you do, right, once you get the measurement back, you will want to redesign your segments better in order to meet their needs. So this is kind of like a first systemic framework. So segment-specific intervention is where a lot of uh, services redesign will need to happen. And this is where I think the second framework helps us to think about how to really design really do systemic services design, right? So we kind of like learn this along the way, and then I kind of put it together into this health system transformation playbook, whereby in systemic services redesign, we cannot just respond to the problem, right? We have to also respond to the problem at scale. So while we want to prescribe empathetic and solutions for the problems, we have to think about how will the solution scale at different levels of the healthcare system and at the health system. And then while we are trying to implement solutions and we are trying to implement solutions at scale, we often face a lot of different stakeholder challenges with different needs, different political requirements, different funding strategies and things like that. So there's a lot of significant local context issues and uncertainty. And the way we deal with that is to include complexity thinking as part of the transformation process and making sure that we are very clearly thinking about design, or are we thinking about scaling, right? And how are we thinking about uncertainty and complexity related iterations through time, right? And in an integrated fashion, right? So I'll give you some examples following here from the outputs of how we did this. And one of the things that came out of doing these 3 steps in succession, right, was this transformation playbook methodology, right, where we involve people in storytelling to see the system, and then we bring them together to understand the system and understand where the system needs to go, right? And then from there, we work with them to find the next possible steps to take. So these are kind of like the 3 steps of HSTP, which is fully described in the paper, kind of explains how we did all the examples that I'm going to talk about later. But I'll come back to the HSTP in a lot more detail later at the end of the talk. I want to start with the examples first so you can see the systemic design output that came from this whole process, all right? So everybody will be very familiar with these kinds of activities, right? This has been my kind of like life over the last 7 years, a lot of design sessions, many groups coming together, and a lot of post-it pads, people talking about their individual stories from their point of view, whether they are a nurse, an operations manager, a doctor, allied health professional, and even management, right? What do management need from the care and services processes, right? So when they come together, we encourage them to tell stories about what is important to them, what do they feel should the future be like, and then a lot of that comes out as ideas and outputs from all these discussions. So you can see, actually, we created so many of these boards of how might we do something, how might we design better care plans, how might we help patients to go home, right, from the hospital back to home, how might we prevent frailty, how might we help people age gracefully and actively in the community. So many design challenges. But a lot of these ideas need to be synthesized, and we want to slow down the process of jumping to solutioning. So that was kind of like we were doing the three-step process in a way by looking at all these design ideas, solutions that people have given to us, but we didn't immediately solution it. We modeled it out, and then we step by step work towards possible solutions, right? So from here, we had to synthesize, and you can see that the synthesis process, right, led us to a lot of what I call understanding existing models, understanding and distilling the design principles for future state health systems delivery, right? And then also understanding if we were to put in place certain future state delivery systems, what might be some of the unintended consequences that we want to prevent, right? So this slide is not meant to be read, but I just wanted to make a connection between the many design sessions and the thousands of ideas that were generated over the last 7 years. And we continue to collect ideas on the day-to-day basis, right? But it must add to the continuous model building process that is happening as we lead change and transformation. So this is one distillation whereby we understood from the stories that people are telling us, what are the existing practices, existing structures and mental models, and then what was their aspiration for a future state design system, and then what are the unintended consequences that we must prevent, right, as a result of designing it differently, right? So from here, actually, we distilled the unified care model, which is defined as a new type of care model, not from a provider perspective, but from a resident perspective, right? So a lot of care models today are from the provider perspective, a hospital's care model, a profession's care model, like a gastroenterologist care model, a diabetologist care model, or a physiotherapist care model, or it could be a disease condition related, for example, a diabetes care model. So we think that the unified care model has to flip the other way around and say the care model is about people and residents. So the unified care model ensures that all residents have a one care plan, emphasizing a fit and healthy life, as well as hassle-free access to dignified, safe, and value-based care by collaborative teams and network. And this is our aspiration, therefore, to then work with the providers to co-create the care for all the patients and the residents, right, together with our staff and communities. And this is also, therefore, an integrated care strategy, right, that drives value, right? So where we are centering the unified care model as people and community-centered, built on the collective strengths, shared goals, and trust and relationships of all the providers coming together to meet the needs of the residents. So the unified care model encapsulates these many design principles of the future and prevents the unintended negative consequences. I'll just highlight one here. For example, today we frequently look at care as defined from the time of arrival to the time of departure from a care facility like a hospital, right? So the boundary of the care system actually is defined by the physical facility like a hospital or a clinic. That's today. But we want to transform this into a people-centered perspective, right? Care is defined from the time a need is identified, such as acute need, right, to the time that the resolution of care has happened, that need has resolved, right? And this could be for a patient, this could be a 90-day process, or this could be 2 weeks, right? Or for chronic disease, it is continuous period, for lifelong period. Right? So we have to redefine our care systems and subsystems according to the needs of the patient. So under the unified care model, this is a central design principle. So this is how our models then build up to ensure that we can implement the unified care model. Starting at the top, Singapore healthcare system, NHG healthcare system is a subset of that. Then we have the Yishun Zone Regional Population Health System. This is where I am, right? So you can see that today care models are inside buildings and inside institutions such as Khoo Teck Puat Hospital, Yishun Community Hospital, right? Each of them have a service delivery system, SDS, right? And then it is the service delivery system that drives the systems, the model that drives the systems, even subsystems in play, right? Down to wards and all that. So we are saying that in future, the unified care model should drive two major sub-models: lifelong care system, right? Model using the lifelong care model, and it should develop an episodic care system, right? Driven by the episodic care model. And then it will have people-centered population segments for people who are living well, living with illness, people who need acute medical care, people who need acute surgical care, right? So this is the current state is on the left side, and we need to transform into the future state, which is people-centered systems based on a lifelong care model and the episodic care model. So a lot of my talk will be about how we implement this, and you can see that this is kind of like a systemic way to look at what people need, not from the provider side, but on the people-centered side, and then we figure out how the supplier or the providers will meet this need. So this is an example of the lifelong care system where we try to implement the future. So all residents will have one primary coordinating doctor with a unified needs assessment, and then one point of contact to help them reach the provider, right, which we call the telehealth network. So we do a lot of mapping, by the way, right? So we map the relationships of how the future model of care will work for the primary coordinating doctor and the different healthcare professionals that need to come together, whether they are in the inpatient setting or whether they are in the primary coordinating doctor team, right? Or whether they are in the community, and how do all these things, right, work together with the patient and the family members, right? So this is kind of like one of the many mappings that we do to help people see where everybody is at with respect to the model of care, with respect to the patient who is in the middle of the model of care. So then this is just an example of how we looked at different needs assessment tools. Again, the needs assessments are from professions, from disease, and we map them and we unify it into one single document. And we tested out the unified needs assessment on the patients and the caregivers to see whether or not it works for them. Oops. I think I pressed the wrong button. Yeah. So when we try to implement this, lifelong care system, right? These are examples of what we have done. We have a integrated medical clinic where the primary coordinating doctor is supported by a team of healthcare professionals, right? And here you can see an example of the primary coordinating doctor inside the integrated medical clinic. And then they work very closely with GPs and primary care services, screening services, and community resources in order to help people integrate back into the community and stay well there. And at the same time, we provide them with a 24/7 telehealth network to help them with care coordination, as well as anticipate their concerns. Like, for example, we will do call outs as well. This is an example of the deployment of the episodic care system where you see we have acute medical care for a 90-day period. So care is started within 48 hours, rapid integrated treatment, but then we will continue the care for 90-day period and measure the outcomes over a 90-day period. Similar for surgical care and similar for elective care as well, right? So now to broaden the picture even more, so you have already seen a cascade of systems, right? The futuristic system includes the unified care model, subsystem, lifelong care model and episodic care model, right? But actually, this model is part of the service delivery system only. And inside a typical health system, you have other subsystems as well. So in order to ensure the service delivery system can function well, right, we also need to make requisite changes in the governance system, manpower system, technology system, financing system, and information system. So later I will touch on whole system transformation initiatives and some of the things we're doing to support this. The other thing that we want to talk about also is that the health system actually is part of an even larger whole Singapore community system. And the community system is something that we work very closely with to enable healthcare to really, really work. So the next few slides, I will show you a little bit about the community system work that we have started to do to integrate health into the community. So this is an example of, I mentioned briefly, we started to set up wellness kampongs in the community, right? And you can see the first three that we set up is in Nee Soon, Central, in different places in the community. And we are starting to build more of these wellness kampongs where the residents can go there and then they can socialize, they can meet their friends, as well as receive certain health advice guided by some of the frameworks and structures that we have put in place in the wellness kampong. Inside the wellness kampong is also where there's a community nurse that can help to do certain healthcare related processes and help them to maybe get better advice on what to do and help to build a community of health together with the kampong volunteers. The other things we do that are slightly more social oriented is like we run sports activities for the aged, and then we involve the community to run those sports activities so that health and sports is now integrated. So this is Go Olympics, which is a pun on the word Olympics, right? The Go Olympics is for people in their golden age or their silver years, and then we try to make health giving activities fun and exciting for even elderly people and bring the young people together with the old people to organize these events. Yeah, so these are examples of non-exhaustive initiatives in the community that will go to a large extent to support lifelong care as well as episodic care going home back into the community. And you can see these are happening in each region in the north. You see a map here showing where some of these assets are parked. So the idea here is to start building ecosystems in the community where lifelong care and episodic care can then go back home into where people have placemaking and where people are most comfortable and spend most of their time and live experiences. So I've covered a lot about segment-specific interventions already driven by different unified care model, lifelong care model, and episodic care models, right? So the next thing I want to talk about is segmentation that enabled us to design this, right? So I'll give an example of segmentation. So this is a simplified view of lifelong care system and episodic care system, but each of them will need their own segmentation model so that we can know exactly who are the residents we are serving. So you can see in this stack model, right, when we maintain people well in the lifelong care segment with ongoing maintenance, right, or segment-specific interventions, then hopefully they can improve and then become less complex. If we don't maintain them well, they'll get worse and then they become more complex. Then when they have a crisis, they get escalated into the episodic care system. When they resolve their need, right, they come back into the lifelong care segment. So this segmentation model helps us to think through the resources needed to design the services that I just talked about, right? So you can see this is an example of a segmentation model whereby we looked at disease complexity, mental illness, and social illness as a surrogate of lifelong need, right? Reason for using surrogates is because we are still in the process of collecting comprehensive needs data. When we have better comprehensive needs data, we can actually design better needs-based segmentation model. But even with these needs data, we are able to group people into 7 distinct groups here, right? And then you can see based on these 7 distinct groups, right, from living well without social issues, early disease, advanced disease to palliative or living well groups. You can see that we were able to break the whole resident population down to different numbers of residents in different levels of the system. Again, so this is idea is population segmentation, but it is about systemic population segmentation, knowing how the numbers translate to at every single level of the system, right? And at every single level of complexity. So this is an example of knowing the exact numbers. And once we know the exact numbers, we can set up a registry of patients, residents, and then we can then bring segment-specific services and care to those population and then track the outcomes of those populations. So I spoke about this earlier, right? Now we know the exact numbers in each of these sub-segments, right? So we are able to bring them the one care plan, the primary coordinating doctor, and we now need to think about the call center capacity, right? And then maybe give them direct lines to reach us. And then the different communities that need to be built, because in each of these communities, we now know the needs of different subpopulations that live in them, and then we can do better targeting. Now, when they come in with an acute problem, again, we have to think about segmentation in a different way. When people arrive in the acute hospital, we normally group them by emergency, urgency, or non-emergencies, 3 different acuity or so-called severity categories, right? So that's how we normally divide up an acute hospital. But then here you can see at the left side here, right, we actually put the lifelong care segmentation model, and at the top part here, we put the acuity status, right, which is an acute hospital acuity status, and then we are able to now create what we call episodic segments. So these are 6 episodic segments that are built on top of lifelong segmentation. And by doing this, right, you can see that we are able to now understand needs in both the lifelong linked to the episodic needs together. So again, it's a kind of systemic segmentation. And when we know the needs in the acute hospital when during an escalation into acute care, we know these are the expected needs, right? Then we can change our inpatient bed management. We can bring better and earlier social support and mental health support to them as well. Okay, so this is an example of how we are doing population segmentation, but understanding how segmentation works throughout the whole system at every level of the system, and then bringing the services to each segment. So very quickly, I'm just going to touch on systematic measurement. Now you will understand that it also has to be done the same way, right? Because segments of populations are at different level. Segment-specific interventions are trying to reach them at different level, right? So the model of care needs to influence our design of the performance measurement framework. And so this is what we have done. So on the left part here, you will see lifelong care. And on the right side, purple part here, you will see episodic care. So right at the bottom, at the micro system level, we think that lifelong care, every resident with a primary coordinating doctor should be anchored by a list of health giving activities or initiatives or strategies that is worked out together with the resident and the primary coordinating doctor or physician. Right. So this is where what we call a resident worksheet, but you can aggregate the performance of every single resident worksheet into a lifelong care population action list. So just now I showed you the populations, the smaller number populations, right? Each of those populations can have a performance based on the individual resident worksheets. And then this can then group up into performance at the geographic level or at the program level. Now, important to note is that every crisis, just now I said, right, is actually when we are unable to manage patients well, right, then what happens is that they escalate into a crisis. So when they come in with a crisis, the patient will have a worksheet, and then each of those acute medical and acute surgical populations will have an action list. And then finally, we have the acute medical and acute surgical program dashboards, right? But important point is that all these patients are actually the same people, right? Before they become a patient, they are actually a resident, right? So all the outcomes on the episodic side need to accrue to the lifelong side. So we bring the data from the episodic side into the lifelong one care plan performance as well. For example, the number of ED visits as well as the cost of care on the hospital side need to add to the utilization as well as the total cost of care on the lifelong side. So this is at the provider level in a way, right? Below this line is at the provider. But then we can now look at performance of our management teams from meso system and up. We can take data and performance indicators from both the lifelong care side as well as the episodic side and pull the data into clinical department dashboards as well as management dashboards. And then we can also share that performance data, right, with our different partners that are supplying care together with us. So these are ongoing work that we are doing. I just want to highlight that this is yet another example of looking at performance measurement and performance measurement reflected in dashboards. But then we look at it in a systemic way and see how to aggregate the data from right where it really matters from the patient and from the resident right up to the system, what I call the arrow here, right? What I call a vertical logic in the system from micro, meso, and macro. So you can see these are the outcomes stacking up and then the episodic outcomes adding into the lifelong care outcomes stacking up. These are just an example of the various types of indicators. There's a lot of details, so I won't get into it, but you can see that we worked out how an indicator that is important, right at the micro level will be added to a indicator right at the macro system level. Okay, so all those are the value-based care transformation of population segmentation, segment-specific intervention, and finally systematic measurement across the whole system, right? But I also briefly said that health system transformation is more than service delivery system transformation, right? More than just a unified care model. So we need to take a whole health system approach, including the community system approach as well, right? So this is where we need to think about other systemic frameworks that are more than just this value-based framework, right? Segment-specific interventions is kind of like service delivery transformation right at the top. So this is where I took the WHO health system framework. And you can see that in addition to service delivery system, right, WHO says that every health system actually has a governance system, a human resources system, products and technology system, financing system, and then health data IT system. So this is how we then look at what else needs to be done at the rest of the system in order to support the services delivery transformation, which is happening using the unified care model, right? So if you plunk in all the things I said at the top here, kind of like briefly mentioned, segmentation model, ecosystem development, one care plan, needs assessment. So these are kinds of things like we did at the above for the services transformation. But at the governance system, right at the bottom here, you will see that this is kind of like the other things we did, including the design of the transformation playbook, which is a way to help our leadership do it more systematically and to think about how to engage the different teams at different levels of the system in conversation. So the designing of the health system transformation playbook was actually a governance and leadership initiative to accelerate whole system transformation. Then, of course, some of the other things we are doing elsewhere, which I don't have time to get into, right? So I will skip that. I'll spend the last bit of time mainly unpacking a little bit about the transformation playbook, which is what this talk is about, right? Okay. So earlier I said that the health system transformation playbook has 3 steps, right? It has storytelling where we bring people in to tell us their existing mental models, as well as what they think they want of the future. But we can't stop there, so we bring them together to model out the future. And then after that, we kind of don't jump to solution. We slow them down in these two steps of the process, right? Then we engage them in pathfinding based on the model. Once you have a model, what can we do, right, to bring the future into reality, right? So there are many steps in this process, right? And you can see it all in the paper. Is discussed in the discussion section, and the limitations to all these steps are also discussed. I thought it's important to share a little bit about this because um, it doesn't always follow a step-by-step approach, right? There are 5 steps each. Of course, it's 15 steps. It doesn't follow in a linear way. Very often, there are numerous conversations throughout the organization. I think I must have at least like hundreds, if not thousands of conversations over the last 7 years. So, but essentially what I'm always trying to help the system to navigate is collecting stories, right? And helping people to clarify what their primary change idea in their story is about. And then getting them to actually identify which system are they working on. Is it the service delivery system? Is it the financing system? Is it the technology system? What system does their change idea actually apply to? And then another important thing really is to get them to say, do we have a model already? If we already have a model of the future state that we want, then we should start from there. We should bring in the existing improvement plans or the existing future state models and then say, how does your change idea impact what we are already trying to improve upon based on some pre-agreed model that is correct to date, right? And then that, because storytelling happens through time, it happens through many teams, right? We find a way to bring things into a model that people are willing to build together with each other, maybe one conversation at a time. Then we come back to the model that people have built and said that, oh, you are telling yet another story. How does it impact the model that the other teams have already built, right? So you can, in a way, see the future state models in step 5 here, right, of the storytelling process, right, is asking people to identify what models have already been put into place, right? And if you want to build your change idea, you build it into the model that had already been iterated by somebody else, right? So this is important because we think that this prevents whole system fragmentation, and it really helps people to see what is already pre-agreed and what are people feeling is important or thinking is important to drive the change, right? And then if there's a need to change the model, yes, of course you can change the model, right? But we must change the model knowing that maybe 20, 30, or 100 other teams have reached this current state of modeling, and we must make those changes if and only if the whole system will really improve. I think that is the key message I want to talk about on the point about future state modeling and group model building process, right? So in group model building, of course, there are many ways to do it. I think I highlighted some tips here that I think is important, right? I won't go through exactly the process here. It's an entire workshop that we can go through this by itself. But important here is that once you have a model and you agree on doing some things you agree that the model will help you get to the future state, right? Pathfinding, right, in a way needs to be prescribed by the model. You don't go back to the change idea and say everybody has different change idea and they're prescribing our future state paths, right? We should avoid this situation. And then the change idea has translated into a group model. It is the group model that prescribes the intervention you need to take. However, the interventions will not make sense to everybody because of local context issues, right? Different people have different realities, different resource, different training, and different concerns in the short run. So they are going to have different aptitude as well as different agreement to whether something can be done immediately or not. So this is where we introduce the HSTP action classes, right, to help people see what is a more systematic way of pathfinding, right? Instead of pathfinding directly from storytelling, right? But to pathfind from a model that has been built as a group through time, right? So these are the four action classes, as it were, right? If everybody agrees that the model prescribed intervention, everybody agrees, there's high agreement, and there's very high certainty that the model prescribed interventions will work, right? Then mobilize your resources and prioritize it as a work plan item, right? But if there is lower agreement but higher certainty, means that people feel that it needs to be implemented, right? But somehow they cannot agree on how to do it, or they cannot agree on who to do it, or can't agree on when to do it, then it is not an issue of piloting, right? Pilots are for uncertain outcomes, right? Pilots are not, you can't pilot away agreement, right? So we think that this is where a lot more engagement and conversations, and really about facilitation skill set and bringing people together to collaborate on different things they want. But sometimes in an executive sort of way, you want this and then the other team wants this, but we can do something kind of like building on both each other's strength to implement the model prescribed intervention so that every team gets it done in a particular way that helps them work with their local context. So I think that is action class 2. Then action class 3 is where there is high agreement, but there's low certainty. So here you do more research and you introduce limited pilots on a small population of maybe like 200, 300 people at most. And then you see whether you can collect data to see whether it works. And then last but not least, right, if there's low agreement, low certainty, take note, this is still important. It's not something that you abandon immediately because your model has prescribed this. You want to get this done for patients, but somehow there's no agreement, and there's also no certainty whether it will exactly work, right? So here you limit it even further, and you do a safe to fail probe to test for agreement issues, to test for reactions from your system, right? You can also do research to, or you can do a small, you can evaluate your probe basically, right? Or you can deprioritize it temporarily and then come back to your model prescribed intervention afterwards, right? Just wait for stakeholders to change, or wait for the climate and the context to change. And then you come back to the model prescribed intervention afterwards. Yeah. So this is the 4 action classes. And with that, right, I kind of like finish with the transformation playbook and examples of how we have learned to pull it together as we manage our health system transformation process. So I just like this quote by Oliver Wendell Holmes a lot, right? A lot of people want simple solutions, but we must remind everyone that the simple, elegant solutions that we want, right, is on the far side of complexity. After we have dealt with the complexity, after we have dealt with understanding the issues at different levels of the systems, as well as understanding our stakeholders' context and how they are grappling with their own complexity, and then finding a coherent solutioning process for it, right? The solution that we eventually get will not necessarily be harder or more difficult to do, but having a systematic process will help us have much greater chance of systemic change for the better. So I'm going to end here and ask if anybody has any questions, or if you want to link up with me for further conversations. That's my QR code and that's my email address. Thank you very much.